Hello to all of the GE Primary Care Leadership Program scholars. I'm Dr. David Norris from the Department of Family Medicine at the University of Mississippi Medical Center, and I'm going to be presenting to you on disease screening and applying health maintenance guidelines. We're going to cover a variety of topics today, some related to selecting screening tests, some related to specific diseases we're going to screen for. Before I begin, let me just say congratulations to all of you, and if the work you've been doing is comparable to what we've seen from our scholars here in Jackson, then the future of primary care is bright indeed. So to get started, let me begin with the legal disclaimer that the use of any famous personages or their pictures in this presentation is intended solely as an educational parody. And this does not apply anything about the medical or social state of any of these people. And I also just want to note it is not a HIPAA violation, as these are not really my patients. So just as an introduction to kind of whet your appetite, our first clinical scenario is Mr. Morgan Freeman, who's an 83-year-old African-American male and has been your patient for the last 10 years. He rarely comes in, but you always enjoy the opportunity to see him because of the great stories he can tell about his times in Shawshank Prison and when he was the president of South Africa. You frequently refer to him as stubborn as a mule because he won't come in for his annual exam. Instead, he presents only when he's acutely ill and he's always in a hurry. Today, though, when you walk in the room, you immediately notice that something is definitely wrong. Mr. Freeman is hunched over and appears to be uncomfortable. When you ask him what's going on, he looks up at you and replies, "I just don't know, Doc. My stomach has been hurting more and more." You notice that he is extremely pale, his eyes are sunken, and he has signs of temporal wasting. You quickly flip through his chart and realize he has lost 50 pounds since you last saw him 6 months ago. You collect the remainder of his history and discover Mr. Freeman has been having melanic stools that are small in caliber. Abdominal exam reveals a suprapubic mass, so you order a CT scan which confirms your fear. There are multiple lesions consistent with metastases and a large sigmoid mass. A subsequent biopsy confirms poorly differentiated adenocarcinoma of the colon. Despite aggressive treatment, Mr. Freeman dies 6 months later. So our first quiz, I want you just to think to yourself for a moment and ask which intervention, if done appropriately, has the best evidence that it may have prevented Mr. Freeman from dying of colon cancer. A high-fiber diet, B, avoidance of alcohol, C, a colonoscopy at age 65, or D, an annual DRA. I'm sure all of you got the correct answer that a colonoscopy at age 65 has the best evidence that it would have saved Mr. Freeman's life. We're going to come back to the subject of colon cancer towards the end of the presentation, but before we get going too much harder, I wanted to just review the objectives, what I hope that you'll get from this. I want you to be able to describe the characteristics of a quality disease screening test, identify sources for screening guidelines and discuss the pros and cons of each type of source, describe the levels of recommendation used by the United States Preventative Services Task Force, or the USPSTF, appropriately select screening tests for patients based on age, gender, and smoking status. I should also say also based on their level of sexual activity, and utilize point-of-care tools for selecting screening tests. So disease screening. This is a very important issue, but I don't know that we all always realize just why it's important. So take a moment and think to yourself why this could be, just general principles. I look at it as that there are two main reasons it's important. Number one is it saves lives. By early identification of many diseases, we can actually prevent their progression. We can prevent the sequelae in the short term and save lives in the long term. And then number two is saves money. If you just take a moment to think about hypertension and think to yourself which is cheaper, treating someone's blood pressure for, say, 50 years or one cardiac catheterization after they have a heart attack, it's actually likely to be much cheaper simply to treat their blood pressure. So a quality screening test, everyone here should have taken biostatistics at least once, maybe more than once, and have learned the characteristics of a quality screening test. There are four main ones. First is that you need to have a high disease prevalence. It needs to be something that you're going to see frequently, otherwise that a screening test won't be cost effective. The next important characteristic is that there must be a treatment available. There's no point in identifying the disease if there's not something you can do to stop the disease process. Number 3 is a low cost of screening. We all know from recent news stories that the healthcare system is in a lot of trouble, mainly because of the amount of money being spent, and we simply do not have the resources to throw $1 million at every single patient in the country. This is something I'm going to focus on several times through this presentation, is the public health implications and the cost of healthcare. Number 4 is that we have to have a high sensitivity of the test. Specificity is great if you can have a high specificity, but it's more important that you don't have false negatives. False positives can be ruled out later, but you want to make sure you catch every instance, or at least nearly every instance of a disease when you're doing a screen. I would also argue that a good screening test, the disease needs to have outcomes altered by earlier identification. Certain types of lung cancer, even if you identify them earlier, the patients do know better than later identification. And that's one of the reasons we choose not to screen for lung cancer without symptomatology already present. So where can you find the guidelines? One of the main resources I utilize is the United States Preventive Services Task Force. This is sponsored by the Agency for Health Research and Quality, which is a government department. It is primarily composed of family physicians, internal medicine physicians, and biostatisticians, as well as some pediatricians. So it is very primary care oriented and very, very evidence-based. Additional sources of information come from the various specialty academies, such as the American Academy of Family Physicians, ACOG, American College of Physicians, amongst others. And then there are also disease-specific societies, many of whom issue guidelines, such as the American Cancer Society and American Diabetes Association. So our first full case study. You are a partner in a busy multi-specialty clinic on the East Coast, and though you're a family physician, your partners include a pediatrician, OBGYN, and a general internist. A day after you return from your vacation, your nurse, who has been working with your internist partner, comes to you upset, telling you that your partner insisted on performing a digital rectal examination and a PSA on a 65-year-old male patient of yours, even though it was obvious the patient did not really feel comfortable with the exam. You virtually never perform screening for prostate cancer. You inform your nurse you'll speak with your partner, Dr. House. So this is your homework assignment. I'm giving it to you early. Is why the difference in screening, and are both techniques evidence-based? I would advise you to look at the United States Preventive Services Task Force website, as well as at the American Urological Association. These raise a lot of important issues because sometimes we have guidelines that disagree with one another. So to make a comparison, as between the USPSTF and the AUA, Preventive Services issues guidelines that are evidence-based. They do not utilize expert opinion. Instead, when there's no evidence, they use what are called I statements. They factor in the cost to the system. As I said, they do utilize I statements. That stands for insufficient evidence. And it is composed solely of primary care physicians. The various professional and disease-specific societies can vary a little bit in the types of guidelines they issue. They are often evidence-based, but they do utilize expert opinion to fill in the gaps where there is a lack of evidence. And there's a surprising lack of evidence for many of the things we still do in medicine, although this is rapidly closing. They may or may not factor in the cost to the system. It depends on the individual society and how they elect to issue their guidelines. They may or may not use I statements, although most that I've seen do not do so. And they are also very specialty specific, being composed of only physician members of their societies. So expert opinion, there are some pros and cons to expert opinion. The pros, they're more compassionate towards individual patients. They likely save more lives, but at the cost of the healthcare system, at times anyways. Can fill in the gaps where the evidence does not give us a clear path. Cons, though, there is a practice or selection bias that is involved. If you think back to our prostate cancer example, most urologists what do they see in their practices? They see a large amount of prostate cancer. They lose a large number of patients to prostate cancer. They're going to be more concerned about screening regardless of the effects on the overall system because they're good, compassionate people. A family physician, on the other hand, is going to see maybe 3 or 4 cases a year, maybe more than that depending on their practice. But because of their sample, they're going to be less likely to say we should absolutely test everyone. The other downside of expert opinion is that it is the con of the pro, obviously. The opposite, it sacrifices the good of the healthcare system, in some cases for the benefit of the few. We can think about recent changes in mammography recommendations from the Preventive Services Task Force. For patients aged 40 to 50, they now do not recommend full mammography, but instead suggest physicians discuss screening with their patients. On their website, they discuss how you would have to screen several thousand women aged 40 to 50 to save one life. And while financially that may make good sense, if you're that one woman, though, that may be a very important sacrifice that's worth being made. Or if that woman is your mother or your sister or your wife. So levels of recommendation, these are very important to be able to understand. I'm only going to review the Preventive Services Task Force because each society has their own. So grade A recommendation, this is the Nike recommendation. It means just do it. There's a high certainty that there is substantial benefit from performing the service. A grade B recommendation is still a service that you want to offer. There's either a high certainty of a moderate benefit or a moderate certainty of a high level of benefit. A grade C is more ambiguous. For most asymptomatic people, the benefit will be small, if any, but it doesn't mean that the service is necessarily not to be done. Certainly if the patient has a large number of risk factors, you would consider providing it. A grade D recommendation is a recommendation against the service. There's a moderate or high certainty of no benefit or of harmful outcomes. I do want to throw out the caveat that even a grade D service, you may still offer to certain patients, but in those cases it's usually not as a screening test, but as a diagnostic test for a pathology. And then we have the I statements that I mentioned earlier. To put it simply, this is where the evidence doesn't exist, it's insufficient, hence the I, and we just don't know if the test is worthwhile or not yet. And at these points is when I look for other professional recommendations or use my own professional judgment. In fact, I have something I call the Norris Continuum. I teach this to our medical students each year. And this is kind of how I look at the guidelines and where I go. You should develop your own system, but this may provide you with a starting off place. I go first to the Preventive Services Task Force for the reasons I've mentioned. They're very evidence-based. They do look at the system as a whole, and they are issued by primary care physicians primarily. Then I go to the American Academy of Family Physician recommendations, mainly because this is my academy. These are physicians who have similar practices to mine. I then go to the other specialty societies, to the disease-specific societies, and then I utilize my own professional judgment if all of those fail me. So we have our next case, and that's Mr. Burt Reynolds, who's a 68-year-old white male, former smoker, that you just saw for knee pain after a fall. Because it was a quick visit, you took the opportunity to review his records and discovered that within the last 5 years, he had had a normal colonoscopy and a PSA. He has had his flu vaccines, pneumonia, and zoster vaccines as well. However, before you discharge Burt back to the house of ill repute, you recommend which of the following tests: a DEXA scan, a chest x-ray, an abdominal ultrasound, or fecal cytology. If you keyed in on the fact that Mr. Reynolds used to smoke, you would know that an abdominal ultrasound would probably be the most appropriate test to offer. So AAA screening, and this is from the Preventive Services Task Force, we have a grade B recommendation for a one-time screening by ultrasound for an abdominal aortic aneurysm in all men 65 to 75 who've ever smoked. Grade C recommendation, we know neither for nor against screening men who have never smoked, and a grade D recommendation for not screening women for AAA, whether they have smoked or not. It's important to note that having ever smoked is defined as 100 cigarettes over the course of a person's lifetime, or approximately 5 packs of cigarettes. Many of our patients most likely qualify for this, and it is a very underutilized screen, and that's one of the reasons I wanted to bring it up specifically. Our next case, and please excuse me, one of my young cousins was visiting when I was coming up with these cases, but we have Miss Vanessa Hudgens, star of High School Musical, who is a 17-year-old Hispanic female who comes to your primary care office requesting a pap smear. She first had sex with her boyfriend, Zac Efron, about 6 months ago. This was prior to their agents deciding they needed to break up, of course. And her mother has told her that she needs to start getting pap smears as soon as she starts having sex. So take a moment and ask. You quickly review the latest preventive services guidelines and recommend that Vanessa, and may I suggest that you pause this recording and actually pull up the guidelines. Sometimes it helps to read over them and think through the process yourself. But should she have a pap smear today, should she wait for 3 years, wait until she is 21, or none of the above, again, according to Preventive Services Task Force guidelines. By the Preventive Services Task Force, she doesn't need a PAP for 3 years. Their current recommendation that we are going to go to, oh, I didn't include those, my apologies. Their current recommendation is that you start pap smears within 3 years of onset of sexual activity or the age of 21, whichever comes first. However, this is one of the times where we have disagreement between the Preventive Services Task Force and the other societies. The American College of Obstetrics and Gynecology has actually recommended for all women to wait until age 21. Their reasoning being the evidence shows us that the overwhelming majority of women under 21 who have abnormal pap smears would regress anyways and would not develop to colon cancer, or not colon, cervical cancer, and overall their outcomes would not be altered. So they actually say we can wait till 21 now. Continuing the case, Vanessa then asks you if there's anything else she can do to improve her health or if she needs to be tested for anything. So in addition to counseling about safer sexual activities, abstinence, and the risk of alcohol and drugs, and since you just reviewed the Preventive Services guidelines, would you recommend she be tested for chlamydia only, chlamydia and gonorrhea, chlamydia and syphilis, HIV, or all of the above? And the answer is that she should be tested for chlamydia and gonorrhea based on her risk factors. So in reviewing the guidelines for chlamydia screening specifically, we have a grade A recommendation to screen all sexually active women who are at increased risk. Risk factors for chlamydia, that what makes you increased risk is age under 24, multiple or new sexual partners, inconsistent condom use in non-monogamous women, and women who trade sex for drugs or money. So Vanessa, by virtue of being 17, is automatically high risk. We do have a grade C recommendation for not routinely screening women 25 and older who are not at increased risk, and a I statement regarding screening any men whether or not they're at increased risk. For gonorrhea screening, it's a grade B recommendation. The evidence is slightly less strong for screening all sexually active women or if they're at increased risk for infection. These are the same risk factors as for chlamydia. A grade I recommendation regarding screening men that are at increased risk. And a grade D recommendation against screening men or women who are not at increased risk. For syphilis screening, we have a grade A recommendation for screening persons who are at increased risk. Now, the risk factors for syphilis vary slightly. They really do not have as much of an age requirement, but they do have a previous STI makes you increased risk. Sex workers are at increased risk, those who have traded drugs for sex or money, and then also men who have sex with men, as well as women who have had sex with a bisexual man, and then those with new or multiple partners with inconsistent condom use. There's a grade D recommendation about screening asymptomatic persons who are not at increased risk for infection. Obviously, symptomatic patients we should screen. We're going to talk more about HIV screening in just a moment. So our next case is Angela, and tells you that when she got home from her last tomb raid, she discovered her husband Brad in bed with another woman. She immediately took their many, many children and left, but is now concerned about her risk for HIV, and she asks you if she should be tested. So, you again review the Preventive Services Task Force guidelines and advise Angelina that you do not have enough information to make a recommendation, that she should absolutely be tested, that she should be tested today and again in 6 months, or that she should not be tested. So after reviewing the guidelines, you'll find you really don't have enough information to make a recommendation at this point. You don't know Brad's sexual history or Angelina's sexual history. However, one of the recommendations for screening according to the USPSTF is that if the patient requests the test, it should be performed. So again, grade A recommendation, screen all adults and adolescents at increased risk. We all know the risk factors for HIV, the multiple sex partners with inconsistent condom use, men who have sex with men who engage in high-risk behaviors, sex workers, IV drug users. It is also noted that the African American communities and gay communities in most of the country are at higher risk than the general population, but that doesn't mean that we shouldn't be screening our general population members as well who don't fit into these two groups. So Angelina elects to have the HIV test performed and agrees to come back in 6 months for a repeat test just to ensure she's not in the window period. That evening you decide to do more research on recommendations for HIV screening. So this time you go to the CDC website because you've heard maybe they've got some different recommendations. And after reading their guidelines, you realize that you, A, should screen all adults for HIV, B, shouldn't have tested Angelina, or C, neither of the above. And if you've gone to the CDC website, it's a simple Google to find the exact page you're looking for. You'll know that you should be screening all adults for HIV. So since 2006, the CDC has recommended that all patients in all healthcare settings should be tested, after being notified, of course, regardless of their risk factors, unless the patient opts out. This includes patients in nursing homes, in clinics, in the hospital, in the ER, in transitional care settings, ICUs, psychiatric facilities, everywhere. Now, while this is a great recommendation and has a lot of very important public health repercussions, because we know that HIV is now treatable, many people don't know they have the disease, and that's the primary way that it is still being transmitted. Many insurers, unfortunately, are not paying for simple screening without certain symptomatology present. Even risk factors do not tend to qualify patients for this. So it's something that you also will want to discuss with your patients. I often elect to recommend my adult sexually active patients go to the health department where the testing is much cheaper than simply paying for it in the clinics. The CDC goes further and says that high-risk persons, those that we mentioned earlier, should be screened annually, and that we should no longer require separate written consents. This used to be a very cumbersome process for our patients, but now our general consent for treatment should be adequate for an HIV screen. The CDC also makes the statement that we shouldn't be required to give prevention counseling simply to be tested. Many patients have opted out of testing because they do not want to sit through the counseling about preventing the spread. And it is generally found that once a patient is HIV positive, they're more than open to listening to the reasons. Patients are often very, very nervous about their results, even when they know they're not high risk, and the counseling tends to just increase their anxiety and make them less likely to consent to testing. So back to the beginning, I told you we'd review the colon cancer guidelines before we finished. So for colon cancer screening, Preventive Services Task Force has issued a grade A recommendation that we should screen using FOBT, sigmoidoscopy, or colonoscopy in all adults aged 50 to 75 years old. They note that the risk and benefits of each modality vary. There's a grade C recommendation regarding screening those 76 to 85 years old, except for certain circumstances. These are patients who are symptomatic of colon cancer, perhaps those who are anemic, and certainly those whose life expectancy exceeds probably 15 years. So if you have an adult age 76 who has just run the Boston Marathon, I would be far more likely to screen that patient than someone who has multiple comorbid chronic illnesses, because they're more likely to benefit from the screen. There's a grade D recommendation to not screen those who are older than age 85, because at that age you're more likely to die of something else before colon cancer would become a significant problem. Now, it's important to know our sensitivities and specificities when selecting between the screening modalities. Most of you will probably already know that we tend to use colonoscopy in most circumstances for most patients. For sensitivity, FOBT is the least sensitive, followed by sigmoidoscopy and colonoscopy with the highest sensitivity. And for specificity, FOBT again is the least specific, with sigmoidoscopy and colonoscopy roughly equivalent when they are positive. You may ask, why then do we even consider using FOBs and sigmoidoscopy? And the main reason is their affordability. They're also much safer. Colonoscopy does require sedation, and there is a greater risk of perforation. However, these risks are relatively small when you compare to the risk of undiagnosed colon cancer. So there are some barriers to preventive screening, and those of you who've worked in busy clinics over this past summer, I'm sure are aware of quite a few of them. This is a fairly busy slide, but I think it expresses fairly well some of the barriers. In medicine, time is often considered to be money, and time is something that we often lack. So when a patient comes in having knee pain or GERD, for instance, there's often not an impetus to review their screening and to educate them about the various screens for which they qualify. Additionally, time is money for our patients, and to come in for a preventive health visit when they're not sick and take a day off of work is another challenge for them. Along with time, we have issues of issues of paperwork that go with that, and documenting and again reviewing charts, some of which could be very, very thick, to see what tests the patient has had can often be a challenge. There's also issues of reimbursement from insurers. You have to make sure they pay for certain tests or that the patient is willing to pay if they cannot. And then one thing I commonly see from my patients is there's a lot of confusion regarding preventive screening. I had one patient tell me that she wasn't diabetic until I checked her blood sugar. The truth is she just didn't know that she was diabetic, but she just didn't understand the importance of this screening. You'll also run into patients who they would just rather not know. And I find that's an area where 5 minutes of education can definitely go a long way, especially if you can help them understand that by early identification, in most cases, we can either cure the disease or prevent it from progressing. There are some electronic resources I wanted to show to you today. The first I have here is just a link to the Preventive Services Task Force website and their recommendations. You can click on any disease process here and it will give you the most up-to-date recommendations. It is very possible by the time I have finished recording this lecture, some of these recommendations will have changed. They do so very quickly. You can also subscribe to a listserv through the USPSTF that will notify you via email of any major changes to guidelines. There are also some great apps out there. The main one is the EPSS, the Electronic Preventive Services Selector. In this, you can go in and you put in your patient's age, their gender, whether or not they're having sex, and their smoking status. And it will tell you all of the guidelines that apply to those patients and whether or not they qualify. Sometimes you have to read through a little bit and determine if they're high risk, but it is very, very worthwhile to do. That is available for iPhones and iPads just at the App Store. All you have to do is type in EPSS. You can also get it for Android, BlackBerry, the Palm OS, Windows Mobile, or on the web by going to the link I've listed here, the http://epss.ahrq.gov/PDA. So I end every lecture I ever give with a quote. This one from Dr. Francis Peabody, that the secret of care of the patient is caring for the patient. And if we spend our time caring for our patient, it makes it worthwhile to spend those extra 2 or 3 minutes to review their chart and just maybe to save their life. If you have any questions or would like to discuss anything I've presented today, you're more than welcome to email me. My email address is drnorris, Norris, @umc.edu. I'll be happy to respond, and if we need to, we'll even have them shared with all of the other scholars. Thank you again for your attention. I hope you found this lecture helpful, and I look forward to hearing from you and potentially to working with many of you in the future as colleagues. Have a wonderful day.